Well, I appreciate everybody being here this morning. I heard Dr. Warf was coming out for some other reasons to be in Seattle, and I thought it'd be an amazing opportunity to get him to come and give grand rounds. He's a absolute luminary in the field of pediatric neurosurgery. And part of what we're trying to do today, too, is Dr. Warf's going to give the first half of the talk, and then Margaux Masson-Forsythe, a woman who's in a group called SDSC. They're doing computer vision for surgical training education, and they came together to do work to scale the efforts that Dr. Warf has been doing for his entire career. So the idea today is to bring together Dr. Warf and some of these new emerging concepts of how we use computation to scale and expand our reach and capability. And so at the end of this, we'll try to do a little panel conversation. So a bit about Dr. Warf. Dr. Warf's professor of neurosurgery at Harvard Medical School. He sits in the Hydrocephalus and Spina Bifida chair in pediatric neurosurgery at Boston Children's Hospital. He's globally recognized for his groundbreaking contributions in the treatment of pediatric hydrocephalus and his lifelong commitment to advancing neurosurgical care in resource-limited settings. Dr. Warf had his training at Case Western Reserve and then went on to faculty position at the University of Kentucky. He made a astounding and amazing decision to take his entire family and leave his academic practice and move to Uganda. This was in the year 2000. He was there for 6 years at the Cure Children's Hospital. And my understanding was this was one of the only hospitals caring for millions and millions of children in the continent. We were talking in the car ride over that Dr. Warf was doing hundreds of operations a year on kids with hydrocephalus and spina bifida. While he was there, he pioneered the work in ETV CPC, which many of the residents have had the opportunity to do with us over at Children's, and he's popularized that throughout our field and really changed the way that we look at and approach hydrocephalus. It's hard to understate or overstate the importance of the work that Dr. Warf has done. Along the lines, too, he was telling us in the car this morning that led to an unexpected path through academia with the work that he did and the hundreds of publications that have come out of that work in our field. Dr. Warf is now back at Boston Children's Hospital. He directs the Global Hydrocephalus and Spina Bifida program. He's an amazing colleague and friend. We're very lucky to have him with us today and excited to hear his talk and the work that he's done. And Dr. Ellenbogen wants to add a little color commentary.
Ben, thank you for being here. Ben's one of the most inspirational people I know, and I was just finishing as chief resident when he came there as the first fellow, the first Choroid fellow at Boston Children's Hospital. And I would say, although we're 3,000 miles away, it's been a friendship that's lasted for over 37 years. And and I talk about him a lot, and it's important for you to know about his character, because that's what I admire most about him. He's took high risk with his life, of course, great reward, but it's because of his great character. And I use this, residents have seen this 100 times to understand some of the more important things in life. I asked him once, what an incredible, because I kept in touch with him while he was at Cure. I thought what he was doing, remember, just flash back to 2000, no one was doing this, zero people. Who would in their right mind go to Uganda and take care of millions of people in a non-set-up environment? And I said, what incredible sacrifice. And and Ben replied to me, and this is his communication to me. One of our American friends were there working with an NGO, was murdered. I pronounced him dead on his living room floor. Driving was dangerous. If one of our children had gotten seriously ill or injured, it would have been tough to get different care. So there were many challenges and stresses on our family and our marriage. And when our work started to take off, I had to get things really excited about and busy with, while Cindy did all that goes along with minding the fort and raising and homeschooling 6 children. I've got to tell you, the woman is a saint. That is true. Were it not for our mutual conviction that this was the work which God had called us, we wouldn't have lasted 3 months. But we were convinced, and Cindy remained committed to the whole enterprise, as did my kids. You asked about sacrifices. This was an email to him asking him about sacrifices. So I told you some. But I must say, this was, in many ways, the best years of our family life. We were very close and had some very close friendships of the sort I have not found here in the U.S. The experience was formational for our children. And I never before or since have had the same satisfaction or sense of meaning in my work. That's character, folks. So, Ben, without further ado, for a person who has influenced me, this is how you do it. Okay, Ben.
Yeah, well, I don't know what to say. That's thank you, Rich and Sam. I I haven't read those emails for, that's amazing that they still exist. I want to say that Rich was extraordinarily supportive of me, and he wrote me some emails when we were living in Uganda that were very meaningful to me, very encouraging, and I just want to thank him. I thanked him privately a few minutes ago, but there are little things that people do along your life that you remember and that mean a lot, and the other person may not even know it. So thank you. Um, well, now full transparency. As a just a boy from Appalachia, about the only thing I really know about artificial intelligence is that it's well, artificial. And this is a very unlikely story because it takes us to something that I never would have considered. So it's an unlikely story, and I need to walk you through it so that you know what's happening. Now, the first thing is I need to figure out how to do this. I'll just do, how do I did the right one. Oh, it's not just me. Well, that makes me feel better. That doesn't work either. Ah, there we go. Now, wait a minute. Which button did you push?
Right.
That one. Got it. Okay.
Yeah.
All right. So you've already seen these pictures and you've heard from Rich, and so I don't have to sort of tell you that, he even has the same pictures. But we hadn't been in Uganda very long before I realized that I had a big problem. And I'll get back to the big problem in a minute. But first I need to give you a little background. As you all know, hydrocephalus is a buildup of fluid in the ventricles. In babies, it causes a large head. And if it's not treated, there's suffering, there's disability. And from the old literature, we know that untreated, about half of the kids will die by the age of 2. The main cause of infant hydrocephalus in sub-Saharan Africa is infection, very unlike here. These are neonatal infections, children that survive those and go on to develop hydrocephalus. You'll see in this CT scan here, which is fairly typical. It's a bad case of it, but there's pus in the ventricles, there's missing brain parenchyma. About 2/3 of the time, the aqueduct is obstructed. And in our first 1,000 cases, post-infectious hydrocephalus accounted for about 60%. The next most common single cause is myelomeningocele. And then there's a hodgepodge of other non-post-infectious problems. You'll note that post-hemorrhagic hydrocephalus of prematurity, which is a big cause of infant hydrocephalus here in our context, is virtually unknown in low-income countries because the preemies don't survive. There's a substantial burden globally of this very treatable condition. It's estimated that there are about 400,000 new infant cases that develop every year. And about half of those cases occur in sub-Saharan Africa. Now, why would that be? Well, first of all, there's a lot of people in sub-Saharan Africa, population of 1.3 billion. And if you look at that population pyramid on the right there, most of those are kids. Population pyramids in Europe and North America are more rectangular or even sort of reverse, but in places like this where the birth rate is so high, it's mostly kids. There's a high birth rate, about 3 times what it is in the US. As it turns out, there seems to be a high birth incidence of congenital hydrocephalus, maybe twice what it is here. And there's a high birth incidence of neural tube defects, and that may be up to 7 times what it is in the US, which is the case in Ethiopia, as has been kind of recently reported. 70% of the hydrocephalus, though, is acquired post-infectious in children with myelomeningocele. And so when you throw that in, it triples the prevalence of infant hydrocephalus. Most of these cases don't get treated. Why? Well, there's about 1 neurosurgeon for every 2 to 7 million people, depending on where you live in sub-Saharan Africa. And so what that means is that for 1 neurosurgeon every year, there's 400 to 1,000 new infant cases of hydrocephalus. Not only is that all you would do, but it would be impossible to keep up. And there are economic and logistical barriers that prevent kids from getting to the care. They don't get diagnosed and referred for treatment. Oftentimes, still to this day, it's in some areas regarded as a curse. It's a spiritual issue. The children get various forms of traditional treatment. Sometimes the children are not treated, they're neglected. Sometimes they're actually terminated, I guess I would say. So it's very sad that these children are hidden. They don't get identified, they don't get to treatment. There's a lack of transport to get to somewhere where there's going to be treatment. There's a lack of neurosurgeons, as I've already pointed out. There are barriers to care once the family gets to a treatment center. They may not have money to buy a shunt, which is the case in many places. There may not be any shunts, even if they had the money. They run out of them. There are sometimes long wait times to get into the operating room. And there are barriers to follow-up that are similar, logistic and financial. So now back to the problem. I had hundreds of these kids coming, not just from our region, but from all across Uganda and crossing borders, even from Tanzania, South Sudan, Congo. People would hear about, NGOs would hear about the fact that we were treating these kids, we weren't charging them. And so they started to come. And the problem was I could only place shunts. It's all I knew how to do. Knowing that about 1/3 of shunts will fail within a year, about half will fail within 5 years. There's a lifetime risk of failure. As you all know, shunt failure is an emergency in older kids. We do them at 2 o'clock in the morning because the kids are sick and they can die if it's not treated. So most of those failures weren't going to make it back. And I knew that a lot of those kids were going to die. Another thing was, if you look at this baby here, that's not an atypical child that I was treating. Malnourished, baggy skin. I mean, think about tunneling a shunt in that child. It's a setup for all sorts of complications. And then the shunt we had to use was this, at the time, $35 Chabra shunt from India. They worked okay, but they weren't great. So now I introduce you to a friend of mine. This is Pierre Mertens. He's a very well-known, actually, artist in Belgium. And he and I have virtually nothing in common. In fact, when we first met, he sort of had a vendetta against neurosurgeons. Why? Well, he had a daughter with spina bifida who died of a shunt malfunction when she was 12 years old. And as a result of that experience, Pierre developed a real burden for children with those conditions in low-income countries. And he became ultimately the president of the International Federation of Spina Bifida and Hydrocephalus. Pierre and I sort of, at the same time in life, started to have a burden for these kids in Africa. And he knew a neurosurgeon, Belgian neurosurgeon named Michael Vlobergs, who was operating in the UK at the time. And Dr. Vlobergs had started being an advocate for treating infant hydrocephalus with ETV. It was a relatively new thing. And this was a paper he published in 1998, which was the year that I first visited Africa and saw the huge burden of disease there. And he had a 77% failure rate doing ETV in children less than a year of age, but he still advocated for that because it would avoid shunt dependence in 1 out of 4 children. So Pierre really started to push me to do this to the point where he had the Norwegian government donate this flexible ventriculoscope, which was the one that Vlobergs was using, and the video tower and the works. He sent that to us in Uganda and urged me to try doing that, to try to eliminate the dangers of shunt dependence. So I read the manual, put things together. I had never seen an ETV in my life. It wasn't part of my training. Nobody was doing it in kids. There is a logic of using ETV, though, in places like this where shunts are more dangerous. And the logic lies in the different patterns of failure. So the blue arrow there shows the survival curve, and this is work from Ab Kulkarni that he published years ago. I tacked on the extras. But what Ab showed was that most ETV failures will occur early, and then the survival curve plateaus so that late ETV failures are rare, and most failures will occur really in the first 6 months. Shunt failures continue over time, and at about 2.5 years, the lines cross. When you're treating babies with compliant skulls, failure is not such an emergency because the issue is volume more so than pressure. And it's a visible diagnosis. So mom will see that the baby's head is growing again, and they have time to get back to the treatment center for attention. We educate them and tell them what to watch for. When you get older, though, and you're a 10-year-old with a shunt and you have a shunt malfunction, it's an emergency, and a lot of these kids aren't going to get to care in time. So we were operating in the safe zone. Like I said, I'd never seen an ETV before 2001, and I wasn't going to just start doing this. So a friend of mine, whose name you might know, Leland Albright, I wrote Leland and I said, "Have you ever done an ETV?" And he said, "No, I have done a few." I said, "Will you come visit me for a week and let's do some?" So Leland came. We did a number of these cases in a week. We doubled his personal experience, and I kept doing them. Indeed, ETV did have a higher failure rate in the kids under a year of age, but we did a little better than Vlobergs. Not quite half were successful, and those were kids that weren't shunt dependent. So I thought that was a big deal, but I wanted to be able to do better. So that begs the question, why do infants have a lower ETV success rate? Well, what difference does it make? At the time, I was operating in the construct of what I'll call Dandy's bulk flow model, that choroid plexus makes all the fluid and it goes downstream from the ventricles to the subarachnoid spaces and gets absorbed. And so a way to think about ETV is that it makes a hole in the third ventricle and it bypasses an obstruction, the fluid gets out and it gets absorbed. And maybe babies didn't do as well because they couldn't absorb the fluid as well. As it turns out, arachnoid granulations are not fully developed in human babies. And they're not fully developed until around 2 years of age, apparently. So I thought, well, okay, choroid plexus makes CSF, and if we reduce the production, it may boost the success rate a bit. So the question was, could we take this old idea that had been being done in the first half of the 20th century? This is from a paper by Scarf at Columbia, and could we do it in a better way with better instruments, better technology, and combine that with ETV in babies and create a procedure that had better results? Well, in fact, it did. The graphs here are as follows. These are kids with myelomeningocele. The blue bar is the success rate for ETV by itself. And the red bar there is with CPC added to it. And in the spina bifida population, we basically doubled the success rate. Similar for this catch-all of non-post-infectious hydrocephalus. Post-infectious hydrocephalus didn't look quite as good until we figured out later, and this is a paper I did with Ab Kulkarni more than 15 years ago, but we showed that when the prepontine cistern is badly scarred like this, it really decreases the success rate. But if the prepontine cistern here's the basilar artery, sixth nerve, cavernous sinus, when this cistern is open, the results are similar. And so this proved to be very helpful. When we looked at the middle group there, the non-post-infectious hydrocephalus types, it really didn't matter so much what the cause of hydrocephalus was. It even was fairly successful in what some people would call communicating hydrocephalus. And so this was very encouraging. We went on to ask some questions. If you've had an ETV and it fails, or if you try to do an ETV and you abandon it and put in a shunt, does that affect the shunt's survival? Well, it doesn't. Can you effectively reopen a closed ETV and have that have long-term success? As it turns out, you can, and the ones that are most successful are the ones that fail later. And so using this method of treatment, intending to do ETV CPC in every child, sometimes abandoning it and doing a shunt if the cistern was badly scarred, reopening the ETV if that was the cause of failure when they came back, we were able to avoid shunts in about 2 out of 3 of the kids that came to us, which was extraordinarily encouraging. But there were a couple of remaining questions which I wanted to answer. One of those was, okay, I'm doing these operations here in Mbale, Uganda, and I'm saying that we can get this success, but, you know, can the same success be replicated by other neurosurgeons in other countries? So we did a prospective study at 2 different African sites, one in Uganda, one in Nigeria. I wasn't involved. These were neurosurgeons that I had taught to do this procedure. And what we showed was that the results were equivalent at the 2 sites, different hospitals, different neurosurgeons, different sides of the continent. They were equivalent to the kind of results that we had been reporting before. The other question really was one that kept me up at night, and that was, all right, it's great to avoid shunt dependence, but is it as good for their brains? Why would we ask that? Well, we all know that shunts make the ventricles small. This is a CT scan of one of our Ugandan patients. Over the course of 2 years, shunt, big ventricles, they come down, they're small ventricles. Here's a typical case treated by ETV CPC. Clinically improved, apparently the hydrocephalus is treated, but the ventricles don't come down to normal. They stay bigger than normal. And so really, does ventricle size matter? Is that important in terms of neurocognitive outcome? So we started with a retrospective cohort study looking at our spina bifida population. We could do that because for the first 2 or 3 years, I was putting shunts still in most of the spina bifida kids because their ventricular anatomy can be confusing. I didn't feel confident enough to go through a complicated third ventricle floor until I'd seen a lot of the cases. So we had a cohort that had been treated by shunts. We had a cohort later that had been treated by ETV-CPC. We retrospectively did Bailey scales of infant development on these kids, and we found equivalent results between the two groups. It didn't seem to make a difference that the kids had a shunt or not have a shunt as far as their developmental outcome. That gave us the equipoise, if you will, or at least the NIH thought it did, and the IRBs involved thought it did, to do a randomized controlled trial. We picked the worst patient group, really, under 6 months of age, post-infectious hydrocephalus, and we did a randomized trial of shunt versus ETV-CPC as an intention to treat study. My colleagues in this, indispensable colleagues, were Ab Kulkarni and Steve Schiff, who are both way smarter than I am, and we were able to get through this. And encouragingly, our results at 1 year, same, 2 years, no difference, 5 years, no difference. We're now collecting our 10-year follow-up data, and the neurocognitive outcomes and the brain growth and the brain volume were the same in these children, despite the fact that their ventricles sizes were different, as you would expect. And we showed pretty clearly that it's brain volume, brain size, not ventricle size, that determines developmental outcome. So you can have big ventricles and a good brain. So after all this, I've come to think of the ETV-CPC approach as being probably a better global public health strategy. I'm not arguing for its use in the US. Other people are going to decide that. But if you do a mental experiment and you're responsible for 1,000 infants with hydrocephalus, and you either put shunts in all of them, or you intend to do ETV-CPC in the ones that you can, and you play that out based on the African ETV-CPC outcomes. Some get a shunt up front because they have to, some fail and get a shunt, etc. And if you play out the results in putting shunts in all these kids using North American outcomes data, and that includes assuming all patients have emergency access to shunt revision, which they don't, but we'll give this the benefit of the doubt, you wind up with having about half the operations, about half the infections, and about half the deaths that you would have if you just did it the old-fashioned way and put shunts in all these kids. So that, for me, is a fairly compelling argument. In 2020, we started a new nonprofit organization called NeuroKids, and our mission is to help children with hydrocephalus and spina bifida live better lives, and in parenthesis, in low-resource settings, low-income countries. And one of the chief pillars of this program is that we train and equip neurosurgeons in developing countries, in tough places really, to do this procedure and treat their infant hydrocephalus using this algorithm. We have a pre-training curriculum over Zoom, where it's about 3 months of instruction. Some of these folks have never seen inside of a ventricle. They need education on what ventricular anatomy is. They need education on really how to manage hydrocephalus properly, how to do patient selection. And we provide all the equipment that they need. And then there's a point where myself or one of our other bench of mentors goes for an on-site visit. We spend about a week. We try to do about 10 of these cases in the neurosurgeon's own operating room with their team and their patient population. And then when we come back, we continue to mentor them using virtual presence technology. So I'll be sitting in my office. Somebody will be in Zambia doing a case, and I can see everything on my screen that they see on their screen. I can telestrate on the screen. We talk to each other live, and I can continue to mentor them and give them advice, just as if I was standing in the operating room. That's been really helpful. We do that for about 6 months. And then we do things to try to enable patient follow-up. We hire a person there at the hospital, a nurse usually, to help with getting the patients back for follow-up, entering data in our REDCap database, etc., trying to help with parent education. With the spina bifida kids, we help with teaching them catheterization and bowel management. We're trying to enhance patient referral so kids get to treatment. And then we try to leverage what we're doing by taking the people that we've trained and they're doing well and supporting them as new trainers so that they're training other people, preferably in their country, but not always, to do this. Right now, we're in about 16 countries and 20 sites, something like that at this point. So this is our treatment algorithm that we teach these folks. If it's possible to do an ETV, they do that. If the imaging is so terrible that you don't think you can figure out that anatomy, then we place a shunt. Although we do teach them to do, septostomies and fenestrate loculations and complex hydrocephalus, and then put in a shunt. They do the ETV. They look at the cistern. If it's badly scarred, goes to a shunt. If it's not terribly scarred, we give it a try. And if the kid is under 2 years of age, we recommend doing the CPC, but we don't have evidence that it's helpful older than that. So that's the treatment algorithm. But performing a thorough choroid plexus cauterization is not technically easy. You start here at the foramen of Monroe, and that's the easy part. You work your way back in the atrium, and then you go around the back of the thalamus into the temporal horn. This is the hippocampus, and you want to get the choroid plexus in the temporal horn. That takes some practice. That's the hardest part of this procedure when we're training these folks. And it does seem to be important. This is an ETV CPC success score, an intraoperative success score that we worked out with Dr. Kulkarni, who was the author of the original ETV success score that everybody uses. And as it turned out, choroid plexus cauterization, a complete bilateral CPC, was the most heavily weighted of these items in predicting success. Now, why would that be? Okay, so this is the harder part to explain. I've shifted my own paradigm, my own model of thinking about hydrocephalus in a way that I've found helpful. And that is moving to what some people will call a hydrodynamic model. As it turns out, plexus doesn't make all the CSF, and CSF doesn't all get absorbed in the subarachnoid spaces. And there are reasons to think that there's bidirectional water transport in both directions across the ependyma, from the extracellular water in the white matter into the ventricle and back. So things are a lot more confusing than Dandy thought. And it's been pointed out that with every systolic arterial pulse wave that goes into the brain, that needs to be cushioned. And so there are some pulsation absorbers, the subarachnoid spaces, the ventricles themselves, and the venous system. And if you think about it, dysfunction of any three of those pulsation absorbers really explains all the hydrocephalus that we know about, okay? Meningitis, ventricular obstruction, decreased venous compliance. And so there's reason to think that dysfunctional pulsation absorption might increase ventricular pulsation amplitude, and this may be a driver of progressive ventriculomegaly. So let me show you a couple of things. Reading the old literature is sometimes very helpful. I'll just say that I never would have thought of choroid plexus cauterization if I hadn't been looking back at the early 20th century and saying, hey, these guys had some success doing this in a rather crude way sometimes. I like to point out sometimes that Dandy was the first person to do a plexectomy. He was not the first person to try to cauterize the plexus, but his idea was to remove the plexus, and so he did a little craniotomy. He put in his grasping forceps. He drained the ventricles out of their fluid. He grabbed the choroid plexus and ripped it out. That wasn't very good. About 3/4 of the patients died, so that wasn't a good way to do it. But there were people like Scarf who did it in a better way and had some success. Anyway, here's a couple of old experiments that I found very helpful. Bering in 1961, who was also at the Boston Children's Hospital, interestingly, he did this experiment. He had a dog model of hydrocephalus. He put kaolin in the foramen in the cisterna magna, and In this model, he removed the choroid plexus in one of the lateral ventricles. Now, there's no internal obstruction here. Foramina of Monroe are open. He removed the plexus in this ventricle, and he monitored the ICP waveform in both ventricles. When in the ventricle where the plexus was removed, although the mean ICP stayed the same, the pulsation amplitude was very dampened compared to the pulsations on the other side. And this decreased pulsation amplitude prevented the ventricles from expanding despite the increased mean ICP. In the 1970s, Dorocco in Italy performed what you might think of as the converse of that experiment. He took a normal sheep, didn't have hydrocephalus, and he put a pulsating balloon catheter into the ventricle, which was gated to the cardiac cycle. And this balloon would inflate with every systole. And by doing that, he increased the pulsation amplitude in the ventricles, maintained the normal ICP, and what he found was there was progressive ventriculomegaly. So increasing the pulsation amplitude caused ventricle expansion despite the normal ICP. Now, a couple of other observations. This funny, they call it a heat map here on the left. This isn't published yet, but we took the last 15 years of data at Boston Children's in doing this procedure, and we don't have the volume that we did in Uganda, but over the course of time, we have a few hundred. And we used, I say, it's the royal we. People that know how to do this use machine learning to figure out what were the main things that really predicted outcome. And there were two, age and ventricle size, all right? So if you look at this graph, anything above this line is a more than 75% rate of success. Here's the 50% line here. For any given age, take 5 months, the likelihood of success declines as the frontal occipital horn ratio increases. And if you pick one ventricle size, say an FOHR 0.6, the rate of expected success increases the older you get. Now, why would that be? Well, I think it has to do with ventricle compliance. We know that in the human, compliance of the brain and the ventricles is highest after birth. And this declines with age into maturity. And then when you start to get old, like me, your brain starts to get soft again. But for little children, the ventricles are more compliant. They're easier to blow up. It's similar for ventricle size. If you think of the law of Laplace, there's a direct relationship between wall tension, which is the inflating force, and the radius of the container, so that with a given pressure, the bigger the container gets, the easier it is to blow up the container. You experience this every day, well, not every day, but whenever you blow up a balloon, right? It's hard in the beginning, it gets easier and easier, the balloon gets bigger. So the ventricles, I think, expand more easily with young age and big ventricles because of compliance. All right, so we've been doing an intraoperative study with some really smart engineers that I get to work with. And they have a little teeny tiny, almost the size of a hair, solid state ICP monitor that fits down the 1 millimeter working channel of our scope. And in real time, I can monitor the pressure and the waveform as we do the operation. And what we're showing is that, and here's one example, this is baseline when we first get this scope in. We have it rigged so that we don't lose a drop of CSF. There's no in, no out. And here's the exaggerated pulse wave in this baby with hydrocephalus. We do the ETV, the ICP drops, but so does the pulsation amplitude. So that would be consistent with absorbing the pulsations. And then as we do the CPC in this same patient, the amplitude drops further, okay? And that's very similar to Behring's experiment when he removed the plexus. So we're seeing this in real time in human babies. So in summary, ETV may function as a pulsation absorber. It's not just pulling the plug on the drain and letting the fluid out. If that were the case, you wouldn't see this immediate change, okay? Because there's not time between here and here to remove much fluid. We're not draining any fluid out of the ventricle. And it may prove insufficient in very young children because of their very compliant ventricles. And so CPC may act to further reduce that pulsatility, as you see here, and increase the rate of success. So if it's that important, then we need to be able to train our people to do it well. And we needed to evaluate the performance of our trainees doing CPC regarding their efficiency and the degree of completion of the plexus cauterization. So this brings us to the AI part, where I stopped talking. But we teamed up with SDSC, who you're going to hear from in a minute, to do that by artificial intelligence analysis of the operative videos that our trainees send us, so that we can evaluate in an objective way how they're doing with the plexus cauterization. And with that, I'll segue to our other colleague. Thank you very much.
So real quickly, as many of you know, I've been very interested in artificial intelligence, and a subset of that is computer vision. We think the idea is that how do we scale somebody like Dr. Warf? How do we record videos, understand, analyze those, and then share them with colleagues we can teach and train? So, been sort of on this podium for a while with a colleague, Dan Donahoe, pushing the idea of artificial intelligence in neurosurgery. As many of you know, and I'll come back and talk more about this later, one of the first new societies in 80 years is being formed around artificial intelligence in neurosurgery. So I'll come back and share more about that. Dan and I got together, didn't know each other about 3 years ago, to talk about this moment that was happening. Dan had formed up a not-for-profit called the Surgical Data Science Collective, with the idea of taking surgical video using these computational tools to analyze those in various ways. And there's an amazing partnership that happened with Dr. Warf and with Dan and his colleagues to start to analyze these procedures, because many of us who do these have not had often the same success that Dr. Warf has had. And whether we're shorting ourselves on the cord plexus cauterization, we all want to learn and understand that better. And it's hard to be there in every one of Dr. Warf's cases. So the idea is, can you take these technologies, capture these cases? And this broadly can be applied across anything that we do. And there's tremendous interest in this. So we're very fortunate today to have Margaux with us. So Margaux Masson-Forsythe, she is the director of machine learning for the organization. Asked Margaux to come in and talk a bit about the work that we're doing to kind of show the intersection of, Dr. Warf, immense creativity and just passion to do this, and the idea that we need to be able to translate this if we're really going to, allow this to be done around the world, and by, any neurosurgeon who's passionate and wants to be able to do the procedure. So Margaux, appreciate you joining us. I'll pass it off to you.
Thank you very much, Sam. Hi, everyone. Today I will be talking about the work that we've been doing at SDSC to close the global surgical divide, specifically in neurosurgery. And I will also be talking about our plans to develop to the OBGYN and general surgery space. So first, I will start with a quick introduction about the Surgical Data Science Collective. Then I'll be talking a bit more about the AI method that we've been using to analyze video, which is called computer vision. And then I will be presenting some of the early work that we've been doing with NeuroKids on the assessment of cauterization of the choroid plexus in ETV CPC. And then I'll be presenting you the new project and research that we're going to work on and how you can get involved with SDSC. So first, we know that there are 5 billion people worldwide who lack access to high quality surgery. And the impact is even more pronounced for women's health. For example, every day in 2023, over 700 women died from preventable causes related to pregnancy and childbirth. So the challenge with the current surgical training model is that it is one-to-one, as we've seen with the presentation of Dr. Warf. It is often has a lot of costly travel expenses. It is time consuming, and most of the time is a one shot with no continuous feedback, unless with the program like NeuroKids, you get more continuous feedback, but this is something that has to scale more. So the opportunity that we saw here at SDSC is that there is an untapped asset of millions of hours of surgical videos that are recorded, but often overlooked or not used at all. However, there is evidence that AI can reduce training time needed to learn new procedures, making surgical training more accessible and effective worldwide. So our model is that we started with ingesting a lot of surgical video data that we use to train AI models that allow us to share AI insights with partners that support education and research programs, which allow us and the partners to publish common insights, which then connect back with experts who potentially have more videos, or new experts who have videos that we haven't received before, and then it goes on and on and on. And also new procedures are improving the results of the AI insights. So how do we do this, and what is computer vision, the method that we've been using to extract information from the surgical videos? I'll start with a very simple example of a picture of my dog, which is one that I often use. So we have an image here of a dog, Piper. So the first image is classification. We say this is an image of a dog. Then we have classification and localization, where we say this is where the dog is on the picture in the box. Then we have object detection, which is similar to classification and localization, but we have several objects. So we say on this image, we have the dog here in this box and the unicorn here on this box. Then we have instance segmentation that is more granular. We get all of the contours and edges of each object. And then we have semantic segmentation, where every single pixel, which is elements of the images, are classified. So here we still have the dog and the unicorn, but we also have the floor and the background. So how does this look like for surgical videos? Here is an example of the analysis of pituitary tumor surgery, where you can see the tools are being detected, classified, and segmented. So we have the curette and the suction here. We also have the camera speed and the camera motion points. From this, we can use this detection to compute insights over the procedure or for specific phases or steps of the procedure. So here, for example, you can see the surgical tool kinematics heat maps that we're able to generate from this detection. You can think of them as signatures of how the tools are being used throughout the procedure, or again, we can focus on several parts of the procedure. This can be helpful in analyzing correlation with patient outcomes or with performance or with complications. So that brings me to the case study that we've been doing with NeuroKids. So through the SDSC platform, which is called the Surgical Video Platform, NeuroKids surgeons in Egypt, Brazil, Kenya, and the US have been sharing training videos with surgeons around the world. They've been receiving feedback from colleagues through the platform and gaining insights about the procedure. And the new insight that we've been developing in partnership with NeuroKids is the ETV-CPC extent of choroid plexus cauterization. Like Dr. Warf said during his talk, the completeness of choroid plexus cauterization is an important predictor of ETV-CPC success. So if we're able to flag a procedure with a potential poor predictor of ETV-CPC success, that say the choroid plexus wasn't fully cauterized, that is helpful feedback for the training surgeons. So the way we've been developing this model is that we use computer vision to analyze each frame of the ETV-CPC procedure, which recognizes what part of the brain it is viewing. So for example, we are in the lateral ventricle right or left, or we are in the temporal right and left. And within these different steps of the procedure, we have an algorithm that tells us if the choroid plexus was cauterized or not. We're working on making this algorithm more granular to give us more insight, but this is where we're starting with, which gives us an approximation of the percentage of overall choroid plexus cauterization. So this is how it looks like on the surgical video platform. This is a dashboard that we're developing currently, and we'll have some improvements on the presentation. But here you can see that for this specific ATV CPC, we had a high success score because we had lateral ventricle left, right, and temporal horn left, right that were all cauterized. The algorithm told us that they were cauterized because it was able to detect that cauterization happened in this specific localization on the video. On the contrary, this ATV-CPC had a low score because only the lateral ventricle left was detected as cauterized. The lateral ventricle right, temporal horn left and right were detected as not cauterized. So it detected that the surgeon did go into this anatomy, in these anatomies, but no cauterization was detected. And to show you a visual example of how, we look at the cauterization. So here you can see cauterization happening where the highlighted red color is the cauterized choroid plexus, so usually is pretty white. And then you have the yellow detected, that is the choroid plexus not yet cauterized. We showcased this first feature on of our platform during a neurosurgical training program in Tanzania, and we received some initial feedback that most initial users interviewed said that they would watch the procedures video upon receiving the assessment. So that helps with a lot of the issues that we've seen where this is a beginning, a starting point to see that we can receive some sort of feedback from the videos, and then that surgeon would actually go back and watch the videos. Some people said that surgeons work in isolation, so getting this will be helpful in getting objective feedback. And that in the case where they have to do an ETV CPC redo, they could go back, watch the video, but also correlate it with the score that they got. And again, that they would want to go back and see what happened if they get a low score. So some of our future work, we're going to continue this work on ETV CPC choroid plexus cauterization score to improve the AI metrics, but also have more granular scores that will pinpoint exactly where you can go and see the cauterization. We're also going to be working on tool efficiency for craniotomy procedures, which include schwannoma removals. We're going to continue the work we've been doing on tool efficiency for pituitary tumor surgery. And as I said at the beginning of the talk, we will be starting to expand to new fields like the OBGYN. So we're starting the data ingestion for OBGYN and general surgery. But we're also going to be working on spinal surgery outcomes predictor. So if you want to partner with us, we're always looking for more partners to contribute data, to help us shape and use insights and give us feedback or give us ideas on things that you really want to see from your videos and to support our work. A special call out that we're looking for partners in OBGYN and general surgery spaces as we're building this new field within SDSC. And also, if you want to try what I showed to you today yourself, you can go to surgicalvideo.io. We have the ETV CPC dashboard, but if you don't yet have your own procedure videos, you can use the platform library where hundreds of videos have been uploaded already from surgeons all around the world who decided to share their videos within the community of SDSC. So you can go and watch a lot of different procedure types from ETV CPC to pituitary tumor surgery to craniotomies. Thank you very much for having me today. Happy to answer any question that anyone has, and you can contact us at this email address if you have any questions after the talk. Thank you.
I think this illustrates sort of the idea of taking, somebody who's really transformed neurosurgery and brought to us a procedure that can help millions of people, right? And how do we scale Dr. Warf and, allow people to learn how to do this and not just do the procedure, but do it properly. And I think this crosses, all areas of training for us. So this is what I think the future is going to look like. Dr. Kim's on the board of the ABNS, and there's been emerging conversations of what does training and credentialing actually look like, and these tools will, I think, facilitate what the future of that looks like. So for everybody sitting over here, you may at some point in your career just submit videos, and that may be the way that you get analyzed, and whether you're capable of doing those procedures, the quality of the procedures, and maybe when you should retire from neurosurgery, please. So I'll open it up for questions. We're so lucky to have Dr. Warf with us today in Margaux. So
Ben, this is
please ask away.
fabulous. One thing you refer to, and we want to kind of drain your brain of all this experience and information. How do you avoid the catastrophic outcome, the aberrant basilar artery? I mean, you're in countries where we don't have the sophistication, perhaps, of a Doppler or an MRA. So what's the secret to avoiding catastrophic outcomes?
Well, that's a great question. Probably the closest I ever came to that was in Uganda. Of course, no MRI, and I got in with the scope, and I found myself through the floor looking at a basilar tip aneurysm. So I quietly backed out, and the kid got a shot. I have yet to see a basilar artery injury. And I think for me, avoiding that particular thing, it's important to never go through the floor using any kind of energy. Don't go through the floor with cautery. I read at least one case report where somebody had a basilar artery injury because they did the ETV with a laser. Makes no sense to me. And you have to you treat the wire, the tip of the wire, like you would a micro dissector, and you can make fine movements with the tip of the scope, and you can work your way through the floor and through these membranes. Teaching that to other people is not easy, but I must say I'm not aware of anybody injuring the basilar artery in the places that we've trained people to do ETV, CPC. So it may not be that there's a secret to it. It's just that the basilar artery is fairly resilient, and if you're careful, it's kind of hard to penetrate it.
What do you use to get through the floor?
I use the Bugby wire, and I do that. I sort of probe it. I gently push through it. If it's tough, some of these post-infectious cases, the floor is scarred and kind of tough, and you have to kind of work your way through it with sort of a back and forth motion. I will occasionally, if it's very tough, hit it with a couple of pulses of cautery just to weaken it, but I never go through the floor with cautery. And then once you finally get through, if you're lucky enough to have a Fogarty balloon catheter, I use that. In most of these places, we don't have that. I never had it in Uganda. So you gradually, by flexing the tip, you take the wire and you stretch the opening in different directions until you get it open enough, and you put the scope through.
That's decades of experience. Thank you. That's very helpful. Questions? Anybody? Dr. Ojiman's here. Holy mackerel. I didn't know you were alive. Yeah, go ahead, please.
First, the follow-up is enviable. How did you get all that long term?
Question was long-term data.
So that's not easy, and we had a big commitment to that. We hired people to go find patients that didn't show up, which sometimes took 2 or 3 days. Patients that don't come back for follow-up are either doing great or they're dead, pretty much. And so we had he was actually a Ugandan social worker who spoke 5 or 6 of the local languages. And he loved doing this. He loved these kids, and he would go on the backs of bicycles. He'd do whatever was necessary to find these kids in these villages that didn't show up. We had a pretty good rate of people coming back because we encouraged them to, and we'd help them to do that. But certainly patients would have been lost if we hadn't done that. And so we were able to get, I wouldn't say 100%, but virtually 100% follow-up by knowing that the child was doing well and facilitating their coming back for a clinic visit, or finding out that they had died and then trying to do a historical autopsy. More often than not, it was some febrile illness, malaria, diarrhea. I mean, the kids die from so many preventable, mostly infectious diseases. So that's how we do it. It's very intentional. It was very costly in terms of time.
Go, Amy, Dr. Lee.
Thanks. Yeah. Yep. From leaking, right. Well, I kind of learned that the hard way early on. And what I learned was, first of all, I always had these children prepped and draped for a shunt because I didn't know what I was going to find. This was in the first about 3 years, the only imaging I had was a used ultrasound machine, which I learned to use myself. So I did my own ultrasounds on these kids, but the imaging wasn't great, and I never knew for sure what I was going to see. So this was really exploratory ventriculoscopy, if you will. So they were all prepped and draped for a shunt. I make a curved little skin flap, so if you need to put a shunt there, it's not lying under the incision. Go through the corner of the fontanelle by opening, doing a sharp opening of the dura without cautery, and then at the end of the procedure, closing that carefully in a watertight fashion. And so that usually prevents CSF from leaking. I will also say that over time, the size of these children's heads and the severity at which we were getting them came down and improved. Why? Because we also had an effort at public education. We tried to educate the public through the different language, local newspapers and radio stations. This is hydrocephalus, it's not a curse. Kid has a big head. You can come here to Mbali, we treat it, you don't have to pay. That's part of the reason we got all these cases. And so over time, we got earlier referrals. So they weren't all these horrible heads you see on YouTube, no way. Most of them were kids that we were catching, by about 3 months of age before it was so severe. And that was partly from public education and education of the referral base.
I have a question for Margaux. Margaux, how do you get feedback back to the surgeons, and how do they take it? Do they welcome it, or there's some that don't welcome it as well?
So at the moment, all of the feedback is delivered through the surgical video platform. So when the surgeons are uploading their video, they will see it on their own account on the video part of their procedure. To the second part of your question, a lot of the surgeons we've been working with, they want to know and get better if they are not doing something well. So the feedback has been very well welcomed. I think that there is often a trust that comes with the AI component. So how does it work exactly? That's why I often show visual on how do we detect these things. And also we always have a section on the platform where you can actually send us feedback if the result is not what you agree it should be. It's an iterative process where we're always improving the models as well. So we love to receive feedback. So it's a feedback in both ways. We send feedback to the surgeon, they send us feedback. It's really a loop. But most of the time, the feedback is usually pretty well received. And I think that probably people who join the platform want to have this kind of feedback, and a lot of the asks for mentorship is really strong in the field from, my limited experience, it's something that I've heard quite a lot. So people are eager to get any more feedback possible.
How many other surgical things are you doing this? Are you doing it with cataracts and other surgeries?
At the moment, we're doing it for a lot of neurosurgery procedures. So we have the pituitary tumor surgery is our biggest one, and the ETV CPC as well. We also are starting to do the craniotomies and spine surgery and starting the OBGYN. So a total of a dozen procedure types at the moment. But if you count all the craniotomies, it's actually a bit more because all of the subtypes of craniotomies that we have at the moment. So
Thank you.
it's growing.
Mike Williams.
Again, for the presentation, I think you said something about ETV, CBC, and neuropsychological outcome that was important, which is the volume of brain that matters rather than the ventricle that matters. Does that change how you take care of children who need shunts and the size of their ventricles long term?
It's a great question, and the answer is yes. So I try like the plague to avoid smaller than normal ventricles, and I'm willing to accept ventricles that are a little bigger. If you have a child that from early on has really big ventricles and you put a shunt in them, I'm not convinced that getting those, that the smaller you make them, the better it is for the brain. And in fact, of course, we want to avoid slit ventricle syndrome and so forth. So I think if the child is doing well, the head growth is normal, we're starting to do some things with falling brain volume, but in a rudimentary way, I measure the thickness of the cerebral mantle, make sure that that's increasing in the first 2 years. So I don't think it's important to get really small ventricles, and I think in the long run, it's probably better not to take giant ventricles and try to get them to normal, which goes against things I've been taught, but I think it's true.
It's an amazing observation. It's a really important one because that's been argued for decades, right?
Yeah.
Yeah. Very.
And that's why I mostly use programmable valves. So my colleagues don't, but I find that to be an advantage. Okay.
Last question, the chief executive again, Dr. Ojimin.
You learn how to take choroid plexus. You actually confuse causation with association. So for instance, there's difficulty in fragmenting choroid plexus indicative of a condition that by itself.
Yeah.
You need a shunt. Or another example, there's saying, oh golly, when the aneurysm ruptured, that's correlated with poor outcome, but saying, oh golly, didn't cause poor outcome. But how does the outcome? Or is it just common sense of when you get a result? Okay, well, that's not what that is.
Margaux, you want to take a stab at it?
Yeah, that's, like all of Dr. Ojimin's questions, none of us understand what he's saying. I mean, when you're that smart, you just say, yeah, that's still fascinating, Dr. Ojimin. Margaux, if you understood the question, can you answer it, please?
I did not hear the question, actually.
Thank God. Okay, that's all I can say. Thank God. Why don't you paraphrase, ask Margaux? Go ahead.
Yeah, so I think the question, Jeff, is like trying to understand causality, and my answer to this and where I hope all of this ultimately goes is as we get more and more data and we start to archive everybody's surgical procedures and we start to be able to do these analytics and tie that to outcome, we'll have a better idea of causality. I think the thing that's interesting to me about this as it relates to surgical training is this side of the room, what we're trying to teach you are nuances, pearls of wisdom, garner, take away the experience that folks have had by operating for decades and decades, right? So when you're with us, we all will teach you a little thing or something like that. That's what you're not going to find in a book. It's not archived anywhere. And it's this one-to-one educational experience that you have to remember and take away and assimilate into who you are as a surgeon. I think where this hopefully all goes over many, many decades is that we start to acquire all this information and pair it up with outcomes. And so you'll start to understand what are the relationships, what are those things that actually matter in surgery, and then how do you apply that and learn those particular skills, right? So the idea is, can you do simulation? Can you model these things that we know are the best ways to work through a procedure? And at some point during the cases, will there be information presented to you, given an option, this is the better thing to do for a particular outcome. That I think is like the future of neurosurgery and where like I've been personally interested in the idea of taking and amplifying and scaling a Dr. Warf. There's only so many people you've been able to interact with in your career, and to go to Uganda, I personally wanted to go, and at the time of my career, I couldn't come and learn the procedure from you. And I've always regretted that as a pediatric neurosurgeon, not having that experience when other colleagues have. And I haven't had the experience of understanding what you know and the nuances of what you've done to get the outcomes that are quite frankly better than most of us in the United States who do this. So it's a clear example for me of like.
Which makes me nervous. Because it makes me question, you know, my own outcomes. I mean, you know, I don't think I do anything, you know, magical. So if other people aren't getting the same outcomes, that makes me sort of question myself.
But I think for me, it's the opposite, that I think you do some nuanced things that we don't do, or we're scared to do for whatever reason. Like we talk about it quite a lot about when we do an ETV, Amy and I talk about this a lot too, Jeff and Rich. Like, how deep do you go? Are you worried about perforators? Like, how aggressive are you versus how aggressive are we? And does that, you know, impact the outcome of the procedure? And so these are the nuances that may very well dictate success of the procedure or failure. And we just don't know the answer because you've done thousands and you've taught hundreds maybe to do it, right?
Yeah.
So that's where the technology, I think, is so valuable and is going to really transform ultimately what we do. And my excitement about the work that Dan has done setting this up and the amazing, you know, brilliance of Margaux and the computer scientists to start to actually understand what we do, because we can take those visual images and turn them into computation, which then can be aggregated for us to learn.